Okay, let's get started. Welcome everybody to the webinar, Get Ready for Flu Shots. And thank you for joining today. And my name is Ruth Ackerman. I'm the Director of Professional Development at the Ontario Pharmacists Association, and I'm here to be your moderator for this evening. So let me just talk a little bit about OPA. So today I'm going to provide a brief introduction and then I'll introduce the speaker. And as we go along, put your questions in the Q&A. And at the end of the presentation, there will be an opportunity to ask questions. So OPA is Canada's largest advocacy organization and professional development provider for pharmacy professionals across Ontario. With over 10,000 members, OPA is committed to enhancing the pharmacy profession and excellence in patient care. Today, we will be talking about influenza, but I would be amiss to not congratulate pharmacists on the critical role played and that you continue to play in the vaccine rollout and battle against COVID-19. As of September, over 4 million COVID-19 vaccine doses have been administered through Ontario pharmacies. This is a significant feat and demonstrates the integral role of pharmacy professionals in Ontario's healthcare system. Efforts and dedication of all pharmacy professionals. OPA has worked to develop COVID-19 tools and resources for pharmacy professionals and have apprised members of news and updates. Without the support of our members, OPA would not be able to continuously advance the pharmacy profession. Our members make what we do possible. Thank you for all pharmacists, pharmacy technicians, assistants, interns, and students who are working on the front lines and who have stepped up to protect our communities and Ontarians. I'd like to thank Seqirus for their generous sponsorship of this webinar, as well as some other educational programs that we've put together. This is the website, the Ontario Pharmacist website, and it is a page where it contains a lot of the educational programs that you get on influenza vaccines. These are the three programs that we put together. There's a live webinar on real-world evidence, which is a very fascinating part of science and applies to vaccines and especially the influenza vaccine this year. So that's recorded and you can see that. You also might want to see the injections and immunization refresher program. It is live, even though it says coming soon, it is live. It'll just bring you up to speed to get you all prepared for all the things you need to think about, in addition to what Jen is going to talk about today. So now to our speaker. I'm just going to stop sharing so that Jen can take over, and I'll just introduce Jen. So Jen is a community pharmacist and owner of Loyalist Pharmacy in Amherst View, Ontario, and has provided the Kingston and Lennox and Addington areas with patient care for the last 8 years. Jen's clinical areas of interest and specialty include medication management and adherence, travel health, immunization, pharmacogenomics, medical cannabis, pain management, mental health and addictions, palliative care, cosmetic dermatology, and specialty compounding. Working in both the community pharmacy and hospital pharmacy settings, Jen is an expert in helping patients and their families navigate the healthcare system. Jen consistently advocates on behalf of her patients. Jen is also a former OPA board member. Jen first joined the board as the District K, now Eastern Ontario representative in 2017. And in 2019, she was appointed as chair of the board. She's just gone off the board this year. So without further ado, Jen, take it away.
Thank you so much, Ruth. Before I get going, can I just check with you that my screen is appearing properly? Oh, Ruth, I think you're muted, but if you just want to nod for me.
Sorry, couldn't have a webinar without somebody saying that. Yes, it looks good.
Excellent. All right. So thank you everyone for joining us on this lovely Thursday evening. Hopefully most of you are done your practice for the day, and we really appreciate you taking the time to join this webinar when you have other things to be doing, like eating dinner and spending time with your families and relaxing and unwinding. So today's webinar is entitled Getting Ready for Flu Shots. We'll be sharing some clinical pearls as well as some of the operational little tips and tricks that may make this year's flu season slightly easier to navigate within your community pharmacy. My name is Jen Baker, as Ruth so generously introduced me, and I am your past chair of the board of directors and a pharmacist in Eastern Ontario. My pharmacy is located just outside of Kingston in Amherst View. So we'll start today with my disclosures. I have served in the previous year on the advisory board for Sanofi Pasteur's influenza program, and I have received speaker's fee from the Ontario Pharmacists Association for this learning activity today. And the program itself has received financial support from Seqirus in the form of an unrestricted educational grant. We'd like to thank our partners for that and supporting the work that we put forward today. A quick review of our learning objectives for today are to review the therapeutic information for the influenza vaccine options included in the 2021-2022 UIIP program, that outline operational considerations for a successful flu shot program in different community pharmacy settings, to discuss the implications of the COVID-19 pandemic and vaccinations on the UIIP, to answer some of the frequently asked questions regarding the UIIP, and I encourage everyone to ask questions throughout the presentation. We should have lots of time for a Q&A session at the end that we'll do our best to navigate through, and to identify opportunities to educate vaccine hesitant patients. As we all know, we are fighting a epidemic of not only respiratory illness, but also of vaccine misinformation out there. We just kick off the presentation briefly with some flu facts. Just in looking at this slide, which I had used in a previous influenza presentation that I'd spoken on, it struck me very, very obviously that this slide could have been created for the COVID-19 virus as well. So the flu ranges from an asymptomatic infection to very severe infection with hospitalization, ICU admission, and even death. With influenza, only about 50% of infected persons will develop the classical influenza symptoms. So we do often have cases of influenza that go missed or are not actually officially diagnosed through influenza testing and recorded as influenza cases. It is also highly contagious, and infected people are contagious for 2 days before symptoms start and 5 to 7 days after. And it is easily spread through respiratory droplets, which can travel up to 6 feet and persist on inanimate surfaces for 24 to 48 hours. So all of this sounds very similar to COVID-19. And indeed, if we take a quick look at the common symptoms of COVID-19 and influenza, they are very, very similar in many ways, and one can be quite easily confused for the other, which does really reinforce the need for immunization with both vaccines for both viruses, but also reinforces the role of laboratory testing in distinguishing between the two types of infections, because they can present very, very similarly. And as we get into the influenza season, there is concern that this season may look a little bit more severe than previous, and we may be in fact in store for a rougher flu season than we have been in previous years. So when we look at the symptoms of the common cold, they share some, but you can differentiate. And I think it's really important for us to refresh ourselves on what the actual symptoms of these 3 respiratory illnesses are, so that we can properly advise our patients on what to do in case they are presenting with symptoms, because between school, work, social distancing, and all of the precautions that we have in place, giving our patients that good information as to when to get tested, when they should be self-isolating is really critical, and trying to assist our patients in having that good information at hand We also know that influenza in many ways gets a bit of a bad name because so many people attribute name influenza to something more akin to a stomach bug and really misrepresent what the clinical nature of influenza truly is, and therefore often underestimate the severity of the disease itself and hence the importance of immunization. So when we're talking about the importance of influenza vaccination, we're talking about really the importance of alleviating that burden of clinical disease that comes with influenza infection. So we have the normal numbers that we would see in a typical season averaged out, looking at about 3,500 deaths attributed to influenza, about just over 12,000 hospitalizations in Canada, 175,000 emergency room visits, 900,000 physician visits, over 2 million work absences, and over 3.5 million symptomatic infections. So the burden of influenza is, in a normal season, I'll put that caveat because last season was quite different, is quite severe when we look at these numbers. And when we consider the impact of undiagnosed influenza, those numbers are likely a gross underestimation of the true impact on the Canadian healthcare system and the health of all Canadians. Therefore, this is a very important disease to immunize against, and really, understanding the breadth of the impact on our system with the numbers and the demographics here does really play into the importance of educating our patients on why influenza vaccination is important, that they should be immunized as soon within their eligibility criteria before the influenza season truly takes off, and that they should be immunized with the most appropriate product for them. So I mentioned that those would be more normal numbers with the numbers here. When we look at the 2020-2021 flu season, it was exceptionally different than years past. So on the Flu Watch epidemiological annual report for 2019 and 2020, we see that 55,379 lab-confirmed influenza cases were recorded over the course of the influenza season in that year. However, for last year, during the COVID-19 pandemic, where we did see an increase in the number of people getting their influenza vaccine and the impact of the protective measures such as physical distancing and hand hygiene, masking, and so forth, we saw a dramatic reduction in the cases of laboratory confirmed influenza, and we saw only 69 cases in the previous season. What lies ahead of us is somewhat unknown, but there have been examples out of the Southern Hemisphere and situations where we do believe that there will be a potential resurgence of influenza this year, and we could be in fact in store for a slightly worse than normal flu season if some of those trends may hold. So this could be because of the dramatic reduction in cases last year. Our naturally acquired immunity may be lower because fewer people were actually exposed to the influenza virus. When we see the antigenic shift and antigenic drift potential when it comes to the influenza for this year, there could be more cases that escape the immunity that we currently have with herd immunity from vaccination from previous years, as well as our natural exposure in the community. And really, we do need to be stressing that importance of immunization for this coming flu season, regardless of whether or not it looks to be particularly bad. But with that information in pocket, it really is, quite important to keep at the top of mind, because patients may become complacent about immunization. Healthcare professionals may too as well. Thinking back to what was basically a non-existent flu season in the 2020-2021 year. So that information can be found on Canada Public Health's Flu Watch website, including the reports for weekly confirmed cases, as well as the annual reports for previous years. When we look at vaccination rates, we know that vaccination coverage in the general population is much lower than we desire. And herd immunity is something that we've been talking about a lot when it comes to the COVID-19 pandemic and getting or trying to achieve herd immunity when it comes to COVID-19. And, you know, targets of 90% are being set to try and achieve herd immunity, what we consider to be herd immunity. In some cases, for some diseases, thresholds are set lower. However, in these cases, we do see targets set as a goal of 80% immunization in high-risk groups. So that would be people aged 65 and older, or people aged 18 to 64 years with chronic medical conditions. Here, and there you'll see the red line across those two bar graphs, which is our target for vaccination rates in this group. And this is set by the Public Health Agency of Canada, these coverage goals. And we can see that even in these highly susceptible groups, we are falling short of those vaccination targets. We can note that these graphs only capture data up to the 2017-2018 seasons. And with the COVID-19 pandemic and the increase we saw in vaccination in the previous year, we will see those numbers creep closer to that threshold. However, especially in that 18 to 64 group with chronic medical conditions, we are only really approaching 40% vaccination. And when we do total view of the general population, we're typically in the 30 to 35% range, depending on the season. So with the concept of herd immunity being really at the forefront of people's minds and having these conversations about COVID-19, this is the time to really talk about those immunization targets and why they exist, and using strategies like providing good information about the efficacy and effectiveness of flu immunization in preventing influenza, discussing how it's still the best strategy in stopping the transmission of flu, and that really we need to be increasing those vaccination rates, because that complacency that others will be getting their vaccine, so I don't have to, really is not the case when it comes to this immunization. When I think back to my days practicing primarily travel medicine and really running a lot of travel health clinic appointments, when I discussed vaccination with people, and we'd be talking about all the different vaccines they needed in order to have this really big, elaborate bucket type trip. And, and kind of kicking off during the flu season when we had vaccine available, that was one of my leading recommendations. And the number of people that would happily stick out their arms for yellow fever vaccination, which is arguably the most dangerous vaccine we have in terms of the potential side effects and so forth, versus something like the flu vaccine, where they're much more likely to be infected with flu either before or throughout their travels than with any of these other exotic diseases. They'd go, oh, no, I'll take, the Japanese encephalitis, I'll take the rabies pre-exposure, I'll take the yellow fever vaccine, but I don't take the flu shot. We'll talk later on about some of these strategies to reduce that vaccine hesitancy. But I think we will see that, especially with influenza, there are some of these myths that really circulate. And with all of these conversations we've been having about vaccine, whether it's vaccine type and technology, whether it's the importance of herd immunity, whether it's what common side effects are to immunization and the fact that you're not actually becoming ill, this is really a great opportunity to discuss the importance of flu vaccine and really correct some of those myths, because they are rampant out there, as we know, as pharmacists. And, the time is now. So let's jump into the products that are authorized for use in Canada for the 2021-22 season. I apologize for the busy slide. I did my best to try and consolidate some of the important information all onto one chart. But we do have a number of different influenza vaccines that are going to be used in the Ontario program. In total, for the Canadian market, there are 11 influenza vaccines that are authorized for use. But we'll go through some of the ones that are covered in the Ontario UIIP program within this slide itself. So we do have a number of quadrivalent standard dose vaccines available for use. Those encompass the Fluvial Tetra, the Fluzone Quadrivalent, the Afluria Tetra, and the Flucelvax Quad. So the first 4 vaccines that you see in this chart are your standard dose quadrivalent vaccines. So we do have different age authorizations for these products. So now that we have the ability to immunize from 2 and up, it is important to keep in mind that all of the vaccines, apart from the Afluria, are able to be used within the pharmacy-based program for anyone 2 years of age or older. The Afluria is 5 years of age or older, so just be cognizant if you do happen to receive any of that product, that should be set aside for immunization in that older pediatric and adult population. The first 4 of those vaccines are egg-based vaccines, and for 3, my apologies, and the 4th, the Flucelvax Quad, is a mammalian cell culture-based vaccine. So basically, one of the key things to keep in mind here is that we know NACI has recommended that egg allergy is not a contraindication to influenza vaccination. The amount of potential egg protein exposure is exceptionally low and does not pose a risk for most egg or for egg allergic individuals. However, if you do have someone who does have a concern about egg allergy, you do have an option should you receive the Flucelvax Quad, as it is a mammalian cell culture based based out of canine cells and does not actually have any exposure to eggs. So when we're talking about the vaccine technology with people, the different ways in which those proteins are generated and then subsequently purified may come into place, because we do know that people have been generally more educated around vaccine technology with the advent of some of these new vaccine technologies for COVID-19. People that normally wouldn't be able to say the first thing about the central dogma of biology are talking about DNA and RNA and how that translates into proteins and so forth. So this may be of more interest to people this year, and we recommend just before flu season starts, just to familiarize yourself with the type of products that you can answer those sort of questions rapidly and quickly. For all of your standard dose quadrivalent vaccines, the dose is the 0.5 milliliter dose, and each one of those products contains 15 micrograms of hemagglutinin antigen. One thing that I know will be of great interest to those of us on the front lines who are immunizing is how those vaccines are actually supplied. The idea of pre-filled syringes that come without needing to be prepared or reconstituted probably brings tears to many of our eyes when we think back to those of us who have been immunizing with the COVID vaccine. The delicate nature of the mRNA vaccines, reconstitution and prep that goes into the Pfizer vaccine, the additional swirling with Moderna, and the idea of having a nice, robust flu vaccine that, if you flick that vial, if you knock it over, you're not looking to waste the entire thing. But there may even be pre-filled syringes that you just need to attach that needle onto. Really does sound quite glorious. So when we look at the first 3 products, they do come as a multi-dose vial type preparation. And it's just important to keep in mind is that some of them may have different expiry dates post-puncture. Once again, very refreshing is that these vials don't need to be used within the clinic day. We do have that stability data that shows that the Fluvaval Tetra is stable for 28 days post-puncture. So that vial may be used up to 4 weeks from the time you first enter it. And with the Fluzone Quadrivalent and the Fluria Tetra, we are looking at the actual vial expiry date post-puncture. So that is a nice thing if you are getting towards the end of the season. You're not having to waste the rest of a vial because you haven't gone through all the doses in that vial during that one clinic day, or a 24-hour period, or even a 6-hour period. We also see that the Fluria Tetra and the Flucelvax Quad come as pre-filled syringes. So I know myself, I'll be crossing my fingers that I'm going to see some of those boxes come in, take up a little bit more space in my vaccine fridge. But it would be a welcome sight not to have to deal with drawing up the doses and just be able to kind of grab and go in that scenario. So we've covered our 4 standard dose vaccines here. The next one down is our Fluzone high dose, which is for individuals age 65 and over. This is a bit different this year, and I think it'll also be a welcome change for pharmacists as we look to balance out the comparison for that 65 up population. So it is quadrivalent this year, whereas in previous years it had been trivalent. And that means that this is much more clearly the superior product for the 65 and up population. It always has been based off of the NACI recommendation in previous years. Trivalent should be offered on that individual level to those who are eligible because of that increase in efficacy. We know as people age, we see the phenomenons of immunosenescence, where their immune system generally and gradually declines over time. So they're less able to respond with antibody production to either vaccination itself, or less able to respond as robustly to acute infection. We also have this population that typically carries a higher burden of chronic disease, which can impact their ability to mount an immune response. And all of the medication considerations that go along with that. So we'll talk a little bit more about the move to in valency for the Fluzone high dose in a subsequent slide. But it is available in the pre-filled syringes as it was in prior years. But one of the differences this year is that it is a larger volume with the 0.7 mils and 60 micrograms of the antigen present within that. So, we do know that it's 4 times the dose of the standard dose vaccine, and high dose vaccines are one of the mechanisms that we can use in order to increase the immune response to a vaccine. We also have the Fluad product, which is for those 65 years of age and older, which is a trivalent adjuvanted vaccine. And that is an oil and water emulsion and contains 15 micrograms of the antigen. However, it is conjugated to that MS59 adjuvant. One other thing to consider just on this chart before we look to, to talk about some of the things that aren't on the chart, is that those pre-filled syringes that you see here are in fact thimerosal free. So if you do have that rare patient who has an allergy to thimerosal or who has a specific concern, those pre-filled syringes would be suitable to offer in those scenarios. You will note that the live attenuated influenza vaccine, or the FluMist, is not on my list here on this slide. And while it is authorized for use in Canada this year, it is not included in the Ontario UIIP program. So in that case, it would not be funded for individuals who are looking for the FluMist product. It will still be able to be ordered, and you can have patients pay for it. In some situations, their drug plans may pick up a portion of it, but it is not a publicly funded vaccine for this season at this point in time. We did see that change mid-year last year, so who knows what this season holds for us. But at this point in time, if someone does request the FluMist product, it is not part of the UIIP program, so they would need to purchase that outside of the program. FluMist will be available and is not suitable for pregnant or immunocompromised individuals, and can be used in those individuals aged 2 to 59. All right. So told you that was a heavy slide. This sort of takes us beyond Ontario. I'm not sure if any of you practice in multiple jurisdictions, but we do know that the influenza vaccination program, the provincial program, looks different in each province. We are fortunate here in Ontario to have a number of different vaccine products available to us. And I know I personally am hoping that our vaccine supply is and distribution is a little bit smoother than last year, and we'll talk about some of the logistics and timing that way. But looking forward to be able to offer a variety of different products to our Ontario population. But this slide just does capture from Immunization Canada some of the differences across the different provincial jurisdictions, because sometimes that does come up, whether you work in multiple provinces or if you have patients that have homes in other provinces or visiting Ontario, or who do go outside of Ontario for different purposes. This might help you advise them as to what would be available to them in the different jurisdictions. All right, so one of the things that I've sort of sat back and considered, and this is more just postulating that we might see this, but we saw brand preference and favoritism in the COVID-19 vaccination campaign. And I think should be prepared for patients being more educated about what types of vaccine options are available to them for the influenza program, and perhaps developing some preferences which may, or in many cases, most likely, may not be actually evidence or scientifically backed. So refreshing that vaccine technology, checking out the webinar that Ruth had spoken about earlier. It is on OPA's website and on the YouTube channel that you can review some of the novel approaches to vaccine development, and really, being solid in your answers on some of these questions may just help things go a little bit more smoothly in the pharmacy. But I'm hoping that we don't see that same level of brand preference translate out to the influenza program. We also may see patients have more of an interest in the actual technology itself. So remembering really, when we're talking about vaccine, we're really looking at how we end up at the point that the vaccination presents an antigen to the immune system and generates the production of antibodies from there. We had the new technology with the mRNA vaccines, which were quite ingenious in the fact that, they coded for the spike protein necessary for entry into cells, and it used the body's own machinery in order to actually produce those proteins. So they didn't need to be manufactured in other cell lines, such as eggs or mammalian cells, and then further purified. No use of antibiotics in that sense, and really, have great potential in other therapeutic areas as well too. We had the viral vector vaccines, where rather than the mRNA, we had the DNA that was inserted into the viral vector, which then infected our own cells, and once again was translated into RNA, which transcribed into RNA, where it was then translated into the actual spike protein itself. So a further step removed, but with our flu vaccines, we are looking at protein-based vaccines, where we're looking at, in most cases, these purified proteins, apart from the live attenuated, which of course is attenuated influenza virus itself. So the logos on this slide, I just want to make that disclaimer that they're just used to illustrate the point around public perception and not to imply any clinical superiority or my preference whatsoever. I think, that it's really important to consider how we explain this sort of science to patients. And when it comes to influenza vaccine, I think we're going to see, the same I know that we have the consideration from NACI that all standard dose quadrivalent influenza vaccines are somewhat interchangeable. And the principle of the first available vaccine to that patient is the best vaccine applies to the UIIP program as well, especially in times of shortages. But I think, coming up with some layperson type examples on how to explain differences between vaccine products, why we have different vaccines, can be really helpful. I know for myself, I'll just give you the example that I often used when it came to comparing the Moderna and the Pfizer vaccine when we were talking about interchangeability. I asked people, I said, are you a car person? Have you shopped for a car recently? Top of mind for me because I really needed a new car and I was getting to that point. And I said, okay, so if you're a car person, do you know the GMC Sierra and the Chevy Silverado? Essentially, they're the same truck. They're built on the same chassis. So, they're the same coating for the same protein, but they have different badges on them. But so there's, different brands of the vaccine itself. However, when it comes down to the actual mechanics of the truck, they are virtually identical. And if you closed your eyes, you probably wouldn't be able to tell if you were riding in one or the other. Just like when, with your immune system, it can't really tell whether you've been given the Pfizer or the Moderna. It's essentially the same truck with a different badge. And that for my population, Amherst is a little bit of a rural population, using the trucks worked quite well. But I know I've heard lots of people talk about, the Coke and Pepsi, those sorts of analogies that helped break down a really complicated scientific type concept into much more simple, easy to understand examples for the average person. All right. So we talked briefly before with a slide about how we now, with the high dose Fluzone product, we have a quadrivalent vaccine rather than a trivalent vaccine. What that means is we do have that second B strain included in the high dose vaccine. We know that influenza B typically is more severe in the younger population. However, when it does, it is the predominant strain in a flu season. It can cause severe disease burden in the older population. So looking to create that high dose vaccine and increasing the valency really, is something that makes a bit more of the apples to apples comparison a little bit easier. However, when it comes to the science and the studies that are used in the actual recommendations and comparisons, it's not necessarily just saying, okay, well, it is sort of, identical to the standard dose, but 4 times. However, we can use that concept of immunobridging, which is commonly used to increase the valency of vaccines and has been used in examples like HPV or pneumococcal vaccines. And in this case, what was done in order to establish the immunobridging process for the high dose trivalent moving to high dose quadrivalent is that they established the superiority of the high dose trivalent vaccine in the 65-year-old population as compared to the standard dose trivalent vaccine. They then established the non-inferiority of the high dose quadrivalent vaccine to the high dose trivalent vaccine. And then they confirmed the efficacy and effectiveness data from the high dose trivalent vaccine to the high dose quadrivalent. So all this to say is that we don't actually have a study that compares them head to head at this point in time. However, NACI does infer the safety and efficacy from the trivalent high dose studies and recommends the use of the quadrivalent product in any patients for whom the trivalent product was recommended. And that is at the individual level recommendation. However, Ontario has decided at a programmatic level to include the high dose quadrivalent product for the Ontario population age 65 and over. And in cases where both vaccines are equally available, the high dose product should be chosen. However, if high dose product is not available and the patient wouldn't reasonably be able to acquire it easily by going elsewhere, the standard dose product can and still should be used because it still provides greater protection than no immunization and should be offered in those cases. Also new and very exciting for all of us who are going to be running both immunization programs out of our pharmacy, or who are only going to be running either the influenza or the COVID-19. Basically, anyone who's giving any of these vaccines or any vaccines at all is going to be very happy with this new approval by the National Advisory Committee on Immunization, stating that COVID-19 vaccines can be administered without regard to timing when it comes to previous or future immunization. So what that means is that if someone comes into our pharmacy and needs either a first or second dose of COVID vaccine and is eligible for influenza immunization, we are good to go with immunizing them both at the same time. Or if they just had their COVID-19 vaccine 2 or 3 days ago, we can go ahead and immunize with the influenza vaccine without regard to timing. This recommendation was made on the 28th and can be found on the Public Health Agency of Canada's NACI summary recommendations, and definitely advise checking that out. But it is very exciting because this really breaks down one obstacle to getting people immunized, especially if they are vaccine hesitant or needle phobic. And this is in regards to all live, non-live, adjuvanted, non-adjuvanted vaccines. Basically, if it's a vaccine, you can give it at the same time as the COVID-19 vaccine without concern. And this is great news. The previous recommendation to separate out the vaccines was made in order to try to separate out any potential adverse effects and really hone in on which vaccine may have been causing any sort of adverse effects after vaccination. That was important because the COVID-19 vaccines were so new, and ultimately we wanted to ensure that any sort of safety signals were recorded properly and were not inflated because of co-administration of other vaccines. If you are administering vaccines on the same day, the recommendation is, if possible, to use separate injection sites, so ideally separate limbs, or barring that, if the patient truly prefers to have both injections done in the same arm, that they're separated by at least 1 inch. When you're doing your landmarking, take that into consideration if you are co-administering vaccine. Spoke a little bit about needle phobia and reducing pain. So it has been established that about 25% of adults do have a fear of needles. And there are certain things that we can do to reduce pain and improve the experience. Some of the acronyms that are out there that are quite helpful and were originally developed for immunization and medical procedures, but are actually quite useful in other anxiety-inducing situations, are the CARD acronym. So CARD, where C stands for comfort. So encouraging patients to think about ways in which they can be more comfortable throughout the whole procedure. In the case of immunization, it may be something as simple as actually wearing short sleeves to the immunization, rather than having people really trying to yank sleeves up over the deltoid and trying to expose that injection site, trying to not have to have them undressed in the pharmacy or in private counseling area. People tend to be more comfortable in public when they're fully clothed, with some exceptions, obviously, but even just, simple things like that, reminding people to wear short sleeves in reminder emails prior to coming to the injection appointment can be helpful in just increasing their comfort. Other things like having privacy for their injection if they are quite nervous may be helpful. Perhaps lying down if they're more comfortable doing so, especially if they do tend to have fainting type reactions after vaccination. Just anything that can make them more comfortable in the setting. The ideal would be that we'd all have lovely, soft furnished vaccination sites with comfortable chairs and soft lighting and music playing. In the community pharmacy, it's unlikely to be the case. If you have that pharmacy, great. Send me some photos and who did your design. I'd love to talk to them. However, most of these vaccines are being done in some of a clinical setting, but it could be something to think about too if you have someone who would be more comfortable being vaccinated in their vehicle. If your infrastructure and staffing and so forth allows, that could be something to consider offering, because the patient may be more comfortable in their own environment in their car. The next letter is A for ask, and this is for the patient to ask any questions that they might have, either in advance or at the time of the vaccination, and to ask those questions of someone they trust. And in this case, we know patients have a great deal of trust in their pharmacists. We're one of the most trusted healthcare professions. So offering that availability to answer questions around the immunization will absolutely reduce some of that fear response. And doing so in a non-judgmental, evidence-based way, and employing some of those evidence-informed strategies like storytelling to help make your answers relatable to the patient. We then look to R in CARD for relax, and that is to employ relaxation strategies. For some patients, that could be meditation or just mindfulness, perhaps slow breathing, focusing on the in and out of their breath can often be a very helpful relaxation as well as distraction technique, because I know whenever I'm at an appointment and I'm instructed to breathe, I actually have to think about how to do it, even though it's something we do all day, every day. So just anything that will help the person relax physically as well as mentally will be helpful, because we know that physical relaxation, a more relaxed muscle typically has less of a pain response to that vaccination, and that reduction in anxiety that comes with relaxation can be very helpful as well. And then the final letter is D for distract. So in our pharmacy, I do try and encourage distraction techniques to help distract the patient from the actual injection itself. I do encourage people to look away if they're at all nervous, because the visual of the needle itself is often all it takes for someone to really start to panic. And because of this, I also would encourage anyone who, if you do vaccine preparation or the assembly of syringes and needle tips, anything that involves manipulation of the actual syringe and needle itself, to do that away from the patient's line of sight, because that fixation on the visual of it for many people can be quite distressing and really work them up prior to the immunization itself. But when it comes to distraction techniques in the moment, there are several things that can be employed, such as listening to music on headphones, watching a video on their phone or device, reading a book, singing, if it's a child, reading a book, singing a song. As a practitioner, if someone isn't employing any of these strategies on their own, often I'll make conversation with them. I'll ask them what they're making for dinner, what they have planned for the rest of the day, what their favorite restaurant in town is, while I'm actually going through the process of immunizing them. And often that distraction's very, very helpful. My personal method is to be making that conversation, and then, mid-conversation, just ask them to take a deep breath in, and while they're inhaling that breath, to administer the vaccine. And at that point in time, that usually provides enough of a distraction and physical relaxation for that person that it does reduce some of that pain, or at least I'm told. I give it a good needle, and I make that a big point of pride. One of the things, skipping back to the R in relaxation, even though there is no way of assessing this and it's probably not factually accurate, I do tell everyone that I give the best needle in town, and that usually gets them a chuckle and they go, okay, good. And I often can see people physically relax when I tell them that they're in good hands. So even just that immunizer confidence can be relaxing for some people, because everyone does sort of sense each other's energy for the most part. And if you're nervous, they often will be as well too. And just, presenting that comfortable and confident front to the patient will help them relax. It's hard to relax around someone who themselves feels quite nervous. In order to talk about techniques of reducing the actual pain of the injection itself, we talk about injecting vaccines rapidly without aspiration. I've had some colleagues tell me they were actually asked why they weren't aspirating by patients, but current best practices suggest that because there are no major blood vessels and no risk of actually delivering the injection into the bloodstream, that there's no requirement for aspiration with your IM sites. And aspiration itself usually increases the pain of the injection. So avoid doing that whatsoever. There can also be the employment of topical anesthetics, which reduce pain, and we'll talk a little bit more about those options in a subsequent slide. And just importantly, similarly to how we were doing with COVID-19 vaccinations, just discouraging pre-medicating with analgesics or antipyretics like Tylenol or Advil, because there is some evidence to suggest that it could potentially blunt the immune response to the vaccine. However, medicating after the fact for injection pain or side effect discomfort is absolutely fine, and encouraging patients to do so to treat the symptoms as is appropriate for their own personal situation is absolutely appropriate. We can also try tactile stimulation near the injection site, especially in pediatric patients. Sometimes rubbing the skin near the injection site can reduce the sensation of pain, or looking at doing things like having positioning for children that supports them and reduces anxiety in young children, things like very young toddlers, things like skin to skin. If toddlers are breastfeeding, encouraging breastfeeding during the immunization can help soothe toddlers, and you will see some 2-year-olds that still do. So that could be an option if you have the young toddlers coming in, as well as the actual positioning, whether in the cuddle hold or the hug hold, that way with the parent. So talking about positioning, let's move to some of these hold strategies here. You'll see here that the straddle hold up top, you have the child that is facing their parent like they were going to hug them, but they're straddling their lap. And the caregiver then uses their hands to restrain the child's arm so that there's no movement of the limb during the actual injection itself. And the other arm, you can't see in this photo, but the other arm is tucked under the carer's armpit so that that other arm can't come out to try and flail. And then in the other hold, you see the cuddle hold, where you do see that the child's right arm tucked in underneath that armpit. The legs are then positioned in between the caregiver's legs to restrain those, and the hands restrain the immunizing arm so that has as little movement as possible. So really familiarizing yourself with how to coach parents on proper positioning can make for a much smoother pediatric vaccination experience. I know we have lots of pharmacists who may be immunizing younger individuals for the first time with this program, as the Flu from 2 initiative was approved late in last year's flu season and often didn't result in immunizations happening in the pharmacy for that age group. Since flu season was mostly done. But from my previous practice, I would suggest that the toddler and the young child population, so that 2 to 5 that we weren't previously immunizing, may actually be less challenging for most people than some of the older children, where that fear response has been more firmly cemented. Toddlers and younger children may not have as firmly ingrained a fear response, and often are smaller and often more able for the parents to position properly and restrain movement. And really, if you were to give me as a practitioner, and this is my personal opinion, I'll fully clarify that, the choice between immunizing a fearful 4-year-old and a fearful 9-year-old, I would take the 4-year-old all day long. But OPA has a fantastic pediatric immunizations course. If you are looking to brush up your knowledge, I would highly suggest registering for that. And all the details are kind of beyond the scope of the presentation, so I'll go on forever, but it is a great opportunity for you to do some learning in that realm. I talked about that calm and confident demeanor. It's especially important in the pediatric population because children are little sponges. I've just learned this myself as a mother. They really are adept at picking up on people's anxiety and energy. So also, if you have the opportunity to talk to parents in advance, encouraging them to try and reduce their own anxiety around the appointment, employing strategies may help the parents relax. When I do have families coming in, I often recommend, if you have multiple people who are nervous about immunization, Most nervous person goes first because the visual of the needle itself will often cause that fear response. And once one child's seen the needle, it's sometimes impossible to get them back in that chair to be immunized themselves. As a sidebar, this is why I always wonder why the media really focuses in on the actual action of injecting when they do all our stories on COVID-19 vaccination, on flu immunization. That focusing on the needle really does us more harm than good in terms of encouraging people to come in. But that's a total sidebar, and I will get back to the content of the slide. So if you do have multiple children that are nervous, separating out that family so that nervous children are not observing their siblings being immunized, and really encouraging parents to not offer to go first and demonstrate how easy or how painless this is, because that strategy typically backfires on a family. So if you do have the opportunity to break up a family and have the children come in one by one, even having the rest of the family wait in a vehicle, that can be very helpful to making appointments go more smoothly. And just keeping in mind that if you are doing pediatric immunizations, to perhaps give yourself a little more time booked for those appointments, so that you're not rushing through to try and catch up, because that can make things go off the rails and then further delay things. It's better to have a calmer experience with a little bit more time than to end up with a panicked child who then is highly resistant, and it's going to take a lot more time to get that injection into them. With children, if they do happen to move their limb during the immunization and the needle comes out, providing you haven't lost any of the injection itself, you can have the patient reposition the child and then provide the remainder of the injection in that second shot. In that case, I would typically not recommend changing out the needle unless the needle itself has actually been damaged, because at that point in time, you're going to want to just get it done as quickly and as safely as you can. I have had that happen to me in the past. It's not a nice situation to go through, but you carry on and you deliver the remainder of that dose to that child so that it's counted as a full dose. With the pediatric vaccinations as well too, just something to keep in mind. We know this from vaccinating 5 and up in previous years, but with the 2 and up population, you may have a larger cohort of children who have never received a flu vaccine before in the past. If they are 2 to under 9 years of age, and this is their first influenza immunization, they do require a booster after 28 days or more after their first shot in order to be fully vaccinated for the flu. So that is for children aged 2 to under 9 years old who have not had prior influenza immunization. One other just tip for pediatric immunizations is to come up with ways of describing what is going to happen so that in a non-threatening way, and often saying that it won't hurt can backfire on us, because we do know that there is a bit of a pinch and some discomfort with immunization. It's often worse in our head than it is in reality, but that it's not actually true that it does not hurt. And then that child loses trust in the fact that what that person is telling them about immunization is not in fact true, and could reinforce the fear response in the future. My analogy that I like to use with children is that, it's more than a mosquito bite, but less than a bee sting. So it sort of relates things through to what things that they may know. Or I tell them it may feel like I took my finger and I flicked your arm. And just using some of that language to help the child know what to expect and let them ask questions, but to be truthful and transparent with them. We talk about this with children, but it seems can apply through to adults as well too. So we did mention briefly the topical anesthetics. This slide has a chart that has some of the topical anesthetics that are available in Canada. This is from the Government of Saskatchewan Manual on Immunization. And topical anesthetics are effective in reducing some of the pain associated with immunization, and can be offered to families who have individuals, whether it's children or adults, who are concerned about the pain associated with immunization. Both children and adults may feel more of a sense of control over the process, which can be important in helping reduce some of that fear and discomfort around the immunization process. And that can be, that control and relaxation because of the topical anesthetic application is preferable and may help slowly reduce that fear response. So topical anesthetics act by inhibiting the generation and transmission of pain impulse across those nerve endings that are located in the dermis. And when used correctly, they cause superficial localized anesthesia at the injection site. And as the needle penetrates the skin, it reduces the underlying pain and muscle spasm, particularly in the case of sequential injections. So if you are going to be giving multiple injections into the same arm, topical anesthetics can reduce some of that muscle spasm that can occur in those sequential injections. And pain relief does occur at the insertion point of the needle, but the patient may still feel some pressure within the muscle upon the injection of the product. They are not thought to pose any risk of decreased immune response to the vaccine. As long as the product is used as directed, they are generally considered to be safe as well. Sometimes, especially in children, you can kind of talk about sort of that magic cream or that magic patch that can really make the whole process more comfortable for them, reduce some of the sting that they might experience. This is just a brief review of the different needle lengths that should be used in the pediatric population. Really what we're looking at is that toddler and up range, where we're typically using a 5/8 of an inch to an inch needle tip when we're talking about the deltoid muscle of the arm. The deltoid still is the preferred site in these cases, but in certain instances, using the vastus lateralis may be appropriate, but typically with any of the age groups that we will be immunizing in pharmacy, the deltoid would still be that preferred site. Talking alternate injection sites, there may be certain instances where the deltoid is not an appropriate site for vaccination. Oftentimes it's the result of the limb itself being compromised, where there may be a reduction in lymphatic circulation. We don't have any evidence to firmly support this one way or the other, but it could theoretically impair an immune response due to impaired vaccine absorption. So if someone has local lymphedema, lymphangioma, axillary lymph node dissection, that sort of thing, we could consider offering an alternative injection site. And in these cases, the vastus lateralis would be an appropriate site. It would be a good idea in advance of having someone who presents to have reviewed the landmarking techniques and injection site identification for this alternate site. We did have a few throughout the COVID-19 vaccination campaign, and when any of my technicians did run into that, they came to get me because it was sort of a first, and becoming more comfortable in landmarking for that is definitely a skill to have if you may have people within your population who require that alternate site. In this case, if you are using vastus lateralis, you'd be looking to use the 1.5-inch needles. So having some of those on hand in your injection supplies is important. A 1-inch needle can be used, providing that the skin is not punched. You can do a little bit of the stretching of the skin to ensure that you actually hit muscle tissue using a 1-inch needle on the vastus lateralis. However, the 1.5-inch needle would be preferred in those scenarios. All right, so in terms of talking about our timing of the UIIP program, this graph is straight off the Ministry of Health's website, talking about the vaccine supply and sort of what that means for the pharmacy program. I think most of us, if not all of us at this point in time who are participating in the UIIP, should have received notification of the date range for our first shipment, as well as our subsequent resupply shipments. So pharmacy will begin immunizing in October, and important is that with the October vaccinations, we are refocusing back on those high-risk eligible populations, so you're 65 and up, pregnant, so forth, type populations, with the general population becoming eligible in November. So that hopefully should reduce some of the panic and real rush in those beginning weeks of the season. We know last week it was open to the general population from day one in pharmacy, which created some shortage situations first right off the bat with last year's flu season that we all suffered through and waiting on vaccine to be delivered. So that timing product availability is available online, and your pharmacy should have received their notification from the Ministry of Health as to when you are getting your vaccines, as well as who you are getting them from, so which wholesaler. So we know that there is usually a rush of vaccination that occurs at the beginning of the UIIP program, and then we see vaccines start to trail off as flu season really picks up. And this is a good thing because it does allow for people to be immunized and have that post-immunization waiting period afterwards to have been completed prior to really when flu season kicks off. So the majority of our injections here in Ontario are given the last weeks of October and in the month of November, which you'll see for previous seasons in that bar graph. Once again, the data for 2020, 2021 is not on there. You'd probably see an even bigger spike in October due to the opening of the program in October to the general population. However, we were still constrained with supply. So November does continue to be the highest month of immunizations. And with this, you can use that information if you do have control over your staffing on your own behalf to try and ensure that you have adequate human resources in place for the busiest times of the influenza immunization program. We also know that more third doses are going to be coming down the pipeline for the COVID-19 injections. Timing is going to be critical to that as to who is eligible and when, and whether that will coincide with our influenza immunization program, as well as the eventual approval of the COVID-19 vaccine for the pediatric population. And of course, any other changes to pharmacy services, like increase in uptake of things like point of care testing for COVID-19 testing, other infectious disease, and of course, your regular pharmacy operations. So if snowbirds are beginning to travel again, despite the land border being closed, we do see people traveling by air into the United States and to other destinations. So if you have people looking to secure vacation supplies and so forth prior to leaving, this fall does present to be a very busy time. So looking at your resources on hand, do you have enough labor? Do you have enough overlap, enough coverage? Do you have enough physical supplies? Do you have enough PPE in place for the time within the program that you're going to need them for? So having that information, that really we look at that rush at the beginning of the program, and it does start to taper off, may help you best plan your operations. So this is once again straight from the Ministry of Health and Long-Term Care's website. This is from the pharmacy program portion of their UIIP website. And it is just a flow chart of, if you have a question regarding the UIIP, who to contact. So knowing that we'll all have a number of questions at any given point in time, knowing that this flow chart exists may help you get your question answered as expediently as possible. So just understanding who you're supposed to contact in relation to any of these questions. That information is available on the government website. So I'm sure everyone's really looking forward to flu season this year, even those of us that love immunizing. I absolutely love it, even though the actual act itself is a technical act. I think, immunization is such a critical part of what we do to keep our populations healthy, and it fundamentally has changed that relationship between patient and the pharmacy professional. and really has changed public perception about community pharmacy as a place of healthcare service. So even those of us, though, that are so passionate about immunization, I think that we can all admit here that there's a lot of burnout within the profession. There is a lot of fatigue. We've been running a marathon with this COVID-19 pandemic, with all of the normal activities of the pharmacy. And then you layer on what has been an exceptionally demanding COVID-19 vaccination campaign. The last several weeks have been even more, I think, emotional for a lot of us who are immunizing in the community, pharmacies, physicians, nurses, paramedics, all of the professions that are out there, pharmacy technicians, everyone who's out there immunizing right now is starting to feel a little fatigued because we're in somewhat of that last 5 miles of the marathon where it's starting to get really, really hard, and we're immunizing people that don't want to be there. So things are taking a little bit more time. Some of those conversations are becoming more challenging. In some cases, patients are being verbally abusive or threatening to staff. And I think we just need to be cognizant that we're entering another really demanding time in our professional workflow at a time when we're already somewhat depleted. And this is where really sort of taking a good hard look at your operations, what you need to do in order to be more efficient, to free up more of your time so that the addition of influenza vaccination doesn't burn you and your staff out, is really key to keeping everyone moving forward and on the same team. So, some of those strategies could or will be discussed in subsequent slides, but it's just really something to look at your individual pharmacy, because we're talking here pharmacies of one pharmacy professional and just a pharmacist, or just a pharmacist and a technician, or just a pharmacist and assistant, through to staff that have multiple pharmacy professionals, support staff, front office staff. So it can look very different based off of who you have at your disposal and what roles they can play. But really take a good hard look at what you can delegate, what you can automate, and what work you can sort of front load and do, so that at the time on the shift, you don't necessarily have to be going through every single motion, because some of that has been done in advance or planned differently. So in some cases, that may look like, still doing things like holding specific clinic days. For COVID-19, you may still want to look at doing smaller clinics versus larger ones with timing based off of your physical space and capacity, looking at your sanitation, ensuring that you're making sure that spaces are wiped down and sanitized. What I've often found helpful to reduce the workload on my staff is to actually put my sanitizing supplies beside each of my immunization stations, and actually asking patients to wipe down after themselves, so that we have stations that are wiped down much more frequently. They're wiped down between each patient, and people, for the most part, have been willing to do so. With COVID precautions, we're also looking at doing things like extended hours or dedicated immunization times to avoid crowding in the pharmacy, and to be able to separate that out from your regular patients, because you will often see large numbers of people who have never been to your pharmacy beforehand for specifically just the flu shot. They may not use multiple medications or any medication at all, and this is sort of their one time in the pharmacy. So trying to plan for dedicated immunization times helps you with both workflow and managing your prescription load, as well as providing a different time and space for different groups of populations. Some pharmacies use things like seniors hours, or dedicated times for more vulnerable populations as well too, to try and keep them more protected, and just having longer times booked in between immunizations. If you have the staff and the capability to do so, even considering a dedicated immunizing team, because of the closer nature of exposure with the act of immunizing versus being more behind the counter or across a desk. Looking at separating your staff out into teams could be one strategy at mitigating if there was exposure and it was deemed to be high risk. In most cases, it will not be because of the use of PPE and the length of time spent in proximity. But in those cases, if there was exposure in someone else's other life, what that means for your staff, as well as using outdoor vaccination or observation spaces. And we'll talk a bit about things like drive-through clinics or offsite clinics in larger spaces a little bit later on. One thing that does help with the physical distancing in some smaller space pharmacies is that we do have a recommendation, this was from last year, that we can reduce the observation period for influenza observation from 15 minutes to 5 minutes if the patient meets certain conditions. So we can reduce that waiting period for people if they have had a past history of receipt of the influenza vaccine and no history of severe allergic reaction, including anaphylaxis to the influenza vaccine or any component therein, or other vaccines. They've also had no history of other immediate post-vaccination reactions, such as syncope or seizure after any sort of vaccine administration. If they're a child, that they're accompanied by a parent or a guardian, or if they're an adult, that they have another person that will be present with them for 15 minutes post-vaccination. And if you have a couple that's coming in to be immunized together, or friends that are coming in together to be each other's buddies, both can be the vaccine recipients for the purpose of the buddy observation. So you wouldn't need a third individual to supervise two people that have gotten vaccination. They can agree to monitor each other post-vaccination. And that the recipient should not be operating motorized vehicle or self-propelled vehicle, such as a bicycle, within 15 minutes after the vaccination, and that they're aware of how to seek post-vaccination advice and medical assistance if they're required. So in those cases, we can reduce the waiting period and observation period in pharmacy from 5 to 15 minutes. And, it's just something to, if you haven't been doing this already with COVID-19 vaccinations, to take a look at your layout and really see what you can do with the space that you have that still allows for safe flow of foot traffic within the pharmacy and create some of these spaces that can be used for observation. One of the things that we really stress is if you have technology that you're employing in your flu program, to really put it to use to the best of its ability. So with technology, some of the services that are available out there have things like wait lists or inventory management features, which will be critical in those early days of high demand, that can help you manage who's coming into your pharmacy for the flu shots themselves. They can have walk-in functionality that can be turned on and off. And some of that functionality can really help manage some of the administrative burden of trying to get the flu program up and running with matching people to doses. You can designate staff members to be responsible for managing the online calendars, ensuring the appropriateness of booking windows to staffing levels, as well as, the closing off bookings when inventory is scarce or when there's no vaccine on hand. You can ensure that walk-in appointments are enabled or disabled based on pharmacy preference and setup. You can proactively communicate with your patients through mechanisms like email and text messaging to remind them of appointments so people show up for their appointments. They show up on time. They know what to do when they get to the pharmacy. They need less coaching once they're arriving. What I found very, very helpful with our COVID-19 vaccination program was to take my clinic list for the day or for a couple of days upcoming and actually proactively send out a lot of my counseling information to patients in the form of an email. So I had a form email that would include all the points that I typically counsel on verbally in advance and send that out to my patients so they could review that in advance, in addition to attaching some of the resources that were made available through either, the Ontario Pharmacists Association and other bodies that created good scientific information that I could send out to my patients. You can also screen for the consent and medical questionnaires prior to the appointment times, and so that you can delegate non-clinical immunization tasks to other staff to free up pharmacist time. So really taking the technology that you have and putting it to work. And I would be remiss if I did not mention OPA's partner platform, Medisys. They've got a fantastic platform that includes things like interactive wait lists, smart triaging, inventory management solutions for unpredictable vaccine supply, documentation that's specific to Ontario, as well as other vaccination platforms, and the ability to manage families. So you do get a discount as an OPA member. And if you are looking for software or even considering a switch, I would highly recommend checking them out. This is just a slide that sort of talks about some of the extras for immunization that you can consider having in your pharmacy. One thing that I like to have is a couple of yoga mats located within my counseling room, so that if patients do need to lay down or if they're fainters, I don't have beds within my pharmacy. I don't have a medical exam bed. So we use yoga mats in order to make people more comfortable. Having some sort of tablet where you could play kids' music, stories, videos. Sometimes this is the time for screen time to help distract people and use some of that technology to help with relaxation. Rolling stools, I found if you have multiple immunization stations, can be very, very helpful in maintaining the proper seated position as an immunizer. And having some of those mobile stations set up with all the supplies that you'd need so that you're not having patients sit in one chair, get up and move to another space. You can leave them sitting in the immunization chair from, for the entire duration of their stay in the pharmacy. Some fun colored Band-Aids, always nice with the pediatric population. And occasionally you'll have the adult that, the big tough guy that wants the Disney princess bandage, or, someone who wants the sparkles. And having some of those Band-Aids where you can offer some of the young children to give them some choice, gives them back some control in the situation. And I try and always have a batch of some of the fun ones on hand. On the far left side, you'll see a burgundy piece of cloth there. That's actually a server's apron. And I found that they were very useful for some of our more mobile type clinics, like our drive-through clinic. In having extra pockets to store our supplies and dispose of any of the paper waste that happened alongside. So we would wear those rather than trying to use all the pockets on our scrubs. And that gave us some additional pockets and let us use our hands better. So just some of those extras that you can have in advance for your flu shot campaign, just to make sure that things are as easy and streamlined as possible for you. I've just got 2 more slides, Ruth, and then we'll open it up for questions. I did warn you, I always go long, but we've got just a mention of drive-through and off-site clinics. So definitely to consider if your pharmacy space allows for it. This is just a picture of one of our pharmacy drive-throughs for the COVID-19 vaccine. We found they worked very well in our pharmacy setting with 1 pharmacist, 3 technicians, 1 assistant, and 1 volunteer. We were able to immunize a patient a minute and have that run nice and smoothly. So we were able to do usually about 250 immunizations in a 3 to 4 hour span after our clinic alongside us closed for the day. So we had full use of the parking lot. We've also done off-site clinics. Just make sure that you have the supplies on hand in order to protect cold chain, and you know what you're doing with regards to packing and transporting vaccines if you are doing any off-site clinics once those are enabled, and you can order a vaccine supply for those. And I'd highly encourage looking into some of those non-traditional type things, because they can be a way of reaching your community in a new way and increasing that convenience. Lots of questions around whether or not technicians will be able to be immunizers, and I can say we sincerely hope so. The Ontario Pharmacy Association has been advocating hard for our technicians to be included in the UIIP program. It is still possible that the policy could be amended to include scope for pharmacy technicians, and OPA is for all opportunities and angles to get technicians mobilized so that we can have you part of our immunization team, because you have been heroes throughout the COVID-19 pandemic. And really, just hats off to everyone who's done that immunization course and really stepped up for the profession. I know we are so grateful as pharmacists. And if you were qualified to reconstitute and administer a Pfizer vaccine, you can absolutely work with flu. So hopefully that is enabled for this flu season. It may not be for the beginning, but we do see from previous years, we may see changes throughout the season itself. And It is the time to talk about vaccine hesitancy with people. We're talking to some of the most vaccine hesitant right now with COVID immunizations. They may be coming back for their second shot at a time where we're giving flu vaccine, and it could be that opportunity to change some hearts and minds. Pharmacists are excellent at this. We are trusted, and just having some of those conversations takes additional time, but really can make a huge difference in somebody's perception around immunization. And just having those conversations, really, being open and transparent and honest about the risks and the benefits, and avoiding passing judgment, because we are in a situation right now where we have camps and a big divide between the immunized and the unimmunized right now, and it's not doing anyone any favors to continue to pass judgment. It's very hard because of some of the ways in which some of the truly anti-vax patients are communicating, but vaccine hesitancy is a continuum. It's estimated only 1% to 2% of people are actually truly anti-vax, and the remainder, in that continuum are more vaccine hesitant to various degrees. Utilizing those stories about why you and your family members are immunized, and storytelling can be a very powerful tool, and consider some of those anecdotes that you might use in having some of those conversations. And I've rushed through those last few slides, but hopefully I've left enough time to have a couple of questions, and I'll turn it back to you, Ruth.
Yes, we do have a couple of questions. Here's a good one. Can a person who recently recovered from COVID get the flu vaccine?
So this is where there isn't a ton of guidance. If they're recently recovered and not using any other medications that could compromise their immune system, the recommendation, I believe, is to go ahead and immunize with flu vaccine. If someone is acutely ill with a respiratory illness, it's usually recommended to defer vaccination. So if someone has active COVID-19, is experiencing symptoms, and or who is being actively treated with potentially immunocompromising medications like high-dose steroids or interleukin-6 inhibitors, those sorts of things, that we would defer vaccination at that point in time. But if someone is recently recovered and there are no other contraindications to vaccination, you should go ahead and vaccinate for influenza.
Perfect. And then we had a very early a question about Fluzone HD vaccine and the amount that's injected. Like, what is the size of the injection? Because we're so used to 0.5 mils of everything. Just wanted to verify the size or the volume.
Yeah, so the volume is 0.7 milliliters. The joy of the Fluzone high dose injection is that it comes as a prefilled syringe. There won't potentially be any issues with drawing up and mistaking one product for another and giving the wrong dose, because it does come as a prefilled syringe in the correct volume. So that's a big plus. And
then finally, this one person is supposed to receive 3 shipments from October to December. Is there an ability to order more than that to respond to clients?
Yeah, so from my understanding, the schedule that was sent out was the initial and then the first shipments. I do believe, and I would have to check in on this just to confirm, but as the vaccine supply stabilizes, pharmacies should be able to order what is needed. Keeping in mind that the caveat around that is, as supply is available and stabilizes, and that will be across the entire province and in different care settings as well too. But from my understanding, and I could be corrected on this at this point in time, I do believe there will be additional opportunities to reorder as the pharmacy needs it to continue to supply your patient population with influenza vaccine.
And I didn't want to ask another question, but I like this question. Could you just talk about, just briefly, about the side effects of the flu vaccine versus the side effects of COVID vaccine?
Yeah, so they're very, very similar, right? When we talk about what the immune system does to respond to the vaccine itself, that non-specific immune response that can include those feelings of being ill. So feeling fatigued, aches, so myalgias, headaches, fever, chills, all can be common side effects with any vaccination. And I do like to sort of point that out to people that, especially right now, right, as I'm counseling people about the COVID-19 vaccination, that it can be possible with any vaccine, and you may feel like you're getting sick, but with flu vaccine, you often think, oh, I got the flu from the flu vaccine. And it's not actually the case, right? It's the typical vaccine side effect profile that people are experiencing. So it's a great time to really discuss that and talk about it and really normalize that with immunization, yes, you may have some crummy side effects that you experience for a short period of time, but there is no actual, in most cases, when we're not talking about live attenuated or live vaccines, that there's no actual virus present. You're not a contagion risk to anybody else. There's no need to self-isolate. It is just common that these side effects can happen after vaccination. And even just that recommendation that people don't need to go for a COVID test or self-isolate or screen out of questionnaires after vaccination, because it is expected that this could happen, could be really useful information for people.
Definitely. Well, I want to thank you, Jen, for an excellent presentation. I know that there'll probably be a lot of people that'll want your slides. So you'll be getting an email from us in tomorrow, probably tomorrow night, and it will have the slide deck and then this recording as well. So if you missed anything and you want to hear it one more time, you can definitely have a look. So I want to thank you very much, and thank you all for coming tonight, and have a great evening.
Thank you.
Thanks. Bye.